Dr. Hoffkamp is the director of obstetric anesthesia at Baylor Scott and White Medical Center Temple and has held that position for 10 years. And prior to that, he completed medical school at Rosalind Franklin University of Medicine and Science, did an internship in internal medicine at Advocate Lutheran General Hospital, and then completed a residency in anesthesiology at the Johns Hopkins Hospital in Baltimore, Maryland. He's spoken at several state and national meetings, has recorded numerous podcasts, and has peer-reviewed publications concerning obstetrical anesthesia. So thank you so much for joining us, Dr. Hofkamp. I'm excited to have you tell us a little bit about yourself and your work as an OB anesthesiologist. And then also would love to hear your favorite part about your role in the birth space.
Well, thank you very much, Amelia, for having me. And thank you for all the participants and logging in and to this session. So I think I really started to get interested in obstetric anesthesia when I was a third-year medical student. I was on my obstetrics and gynecology rotation, and I saw how much the obstetric anesthesiologists were appreciated on the labor and delivery unit, and how much joy and pain relief they brought to the women who requested epidurals. And I thought that, and they seemed to be the most laid back guys and gals on the floor. So that's kind of what I aspired to be. And, 20 years later, here I am. So
I just realized I muted myself. What are the primary medical pain management options that are available in labor and delivery? I know this slightly varies kind of depending on where you're at, but what are those and what are the pros and cons of each of those options?
That's a great question. So I think when we think of pain relief for labor, we think of an epidural. And so an epidural is a medical procedure. It involves a needle in the lumbar space. And there's different kinds of techniques of the epidural. You can do a regular epidural, where you put the epidural needle in, you put a catheter through the needle comes out, the catheter stays in the back. And that's what I'd say probably the majority of epidurals are done in this country. And then there's the so-called combined spinal epidural. And so you put that epidural needle in, and then before throwing the catheter, you put a smaller needle through the epidural needle, and it goes one layer deeper into the back. It punctures the dura. You get into the cerebral spinal fluid, and then you can inject medicine to give some instantaneous relief for labor. And then you pull that needle out, you put the catheter in, and then you leave the catheter in. So the difference with the combined spinal epidural is you get that spinal dose that really kind of hastens or quickens the onset of analgesia. And so there's pros and cons to both of those, but those are kind of the two main flavors of epidurals. And then we have nitrous oxide. And so nitrous oxide can be used under the supervision of physicians. There are lots of different hospitals that allow the midwives to oversee it. And so with nitrous oxide, you get this, the commercially available apparatus is this Nitronox. It's a nitrous oxide mixer. It's engineered so it doesn't get above 50% nitrous oxide. And then you take this mask, you put it on your face, and you take what I call hits of nitrous oxide. And so that's pretty good. It's nowhere near as good as an epidural. And there's a lot of crossover. And so about 2/3 of the people who start off with nitrous will eventually get an epidural before they have a baby. And then other than that, we've got intravenous opioids. And so when you're far out from delivery, you can get longer acting opioids like fentanyl, which lasts for an hour to 2 hours. Once you get further along in your labor, in our hospital, it's 8 centimeters, they stop giving fentanyl because they don't want the baby to come out unnecessarily sleepy. And then, so if you're in that zone of your labor, you can have a drug called remifentanil. And so remifentanil is a very special drug that's not metabolized in the liver. It's metabolized in the tissues. There's enzymes in your bloodstream that metabolize the remifentanil in real time. And it's very quick on, and it's very quick off. And so one of the challenges with remifentanil is that what we'll do is we'll give you a button, and you hit the button, and the remifentanil, you get hit remifentanil, and then there's a little bit of delay between the delivery of the drug and you feeling the effects of the drug. And so unfortunately what happens is that if you were to hit that button as soon as the onset of the contraction started, there'd be a mismatch between the peak of the contraction and the peak of the drug. And so you almost have to see into the future and hit the button before your contraction starts. It kind of sounds impossible, but if you've got regular contractions every 3 minutes or so, you can kind of time those button hits. And like I said, it's the remifentanil. It's better than nothing, but it's not that much better than nothing. It's nowhere near as good as a labor epidural. And then what we can do is we can have our obstetric colleagues do a pudendal block, and that's towards the end of the second stage of labor. And that can provide some good analgesia as the baby's being born. And so all those things come together for the medical options of pain control for labor.
Yeah, I love the option of nitrous oxide being more available for like delaying the epidural, like waiting a little bit longer. Love seeing people using all of these tools to kind of just make sure that they're enjoying their labor experience as much as possible, and mostly, not suffering. So yeah, those are all great options. So my next question is, do those medical options that are available for birthing people, do those differ between a low risk pregnancy and a high risk pregnancy? Or are there certain ones that are unavailable if you're high risk?
So, I mean, there's every patient is different. And so to kind of answer that question, if you like, I would consider a higher risk labor a trial of labor after a cesarean delivery. And so let's say you've had a C-section, and for the second or third pregnancy, you say, I want to try to have this baby without a C-section. And so to do a trial of labor after cesarean delivery, it's called TOLAC for an acronym. It has to be a specialized center that can do an immediate cesarean delivery. And the reason for that is because when you have a C-section, there's a scar on your uterus, and the scar doesn't heal perfectly. It heals to 80 to maybe 90% tensile strength, but it's still kind of a weak point in your uterus. And when the uterus contracts during contractions, there's a chance of that scar dehiscing or separating or rupturing. And then the baby can actually come out of that scar. The uterus can push the baby out through that scar. And so that's a pretty bad complication that happens less than 1% of the time, but it's a known complication. And so if you're going to do a TOLAC, you have to be in a hospital that has the capability to do an immediate cesarean delivery. And so in keeping that in mind, I think a lot of obstetricians and anesthesiologists or anesthetists prefer to place labor epidurals early in people who are TOLACing. And the reason for that is because if you have a labor epidural in place and you need an emergency cesarean delivery, you can try to administer medicine through that epidural that's going to produce a surgical block that you can have a surgery to have your baby via C-section. And so, so if you're TOLACing, they're not going to force you to get an early epidural, but they're definitely going to recommend that you get an epidural. Now, there are other high-risk pregnancies that are high risk for other reasons. Like there are some maternal medical problems that will prevent safe labor epidural placement. Sometimes people's platelets are way too low, and it's not safe to put the epidural in because we're worried about bleeding. Some people have reasons that they need to be anticoagulated. Say you had a DVT during your pregnancy, or you had a pulmonary embolus. They're going to want to put you on anticoagulation medicine. And if we go long enough between the last dose and putting the epidural in, then sometimes we can get around that. But sometimes people come to the hospital and active labor too close to their last anticoagulation dose, and it's just not safe to put a needle in the back. And then some people have neurological problems like Arnold-Chiari malformation or other intracerebral processes going on where we would risk permanent disability or even death if we were to put a needle in the back. So every time we do an epidural on a patient, it's a consultation, and we determine whether it's safe and appropriate to put that epidural in the patient.
Yeah, just really advocating kind of on a case by case basis rather than on like an entire population basis is always a smart and wise decision, I think, as medical providers. What advice would you have for a mom who is considering an epidural? And are there any benefits or drawbacks that you like to make sure that everyone knows that are addressed before that epidural catheter is placed?
So an epidural is a medical intervention. And if you want to have a birth that's without medical interventions, then an epidural may or may not be right for you. And there are certain things we have to do for your safety once the epidural catheter is in. I think one of the biggest things is you can't get up out of bed, because what we do is we give you local anesthetic through the epidural catheter. It makes your leg muscles weak and you can't walk around safely. And so you're going to give up your ability to get up and walk around. The other thing that the epidural does is that it doesn't allow you to feel your bladder getting full. And so you're going to have to get a bladder catheter. There's no way around it. And those are the things when everything goes right. And there's about 1 to 5% of the time we put the epidural needle in a little bit too far, and we get what we call a dural puncture. And we do it all the time with small spinal needles on purpose, but sometimes we do it on accident with the big epidural needles, and that can cause a headache after delivery of the baby. And so that headache can be pretty debilitating, and more often than not, it involves a procedure called an epidural blood patch, where we take blood from your arm or your hand sterilely. It can't be an IV that's already in there. It has to be a fresh stick, sterile draw, sterile gloves, everything. And then we inject that blood into your back by doing another epidural procedure. And most of the time, at least 80% on average for the first blood patch, it will cure the headache. And 90% for the second blood patch, it will cure the headache. And so that's a complication that will happen. It's low. It's like I said, it's 1 to 5%, which is quoted in literature. If you go to a place where they don't train residents or nurse anesthetists, it's probably going to be a little bit lower. But those are things that that you have to take the risk for. Extremely rare complications are bleeding in the epidural space and infection in the epidural space. And those things are so rare that it's very difficult to put a real good, accurate number on what the risk is. And so we try to avoid the risk of infection by doing sterile technique. The epidural is a sterile procedure, sterile gloves, and we don't gown and completely drape you, but it's a pretty sterile procedure. And then for the bleeding, we make sure that your platelets are okay. We make sure there's no other risk factors for bleeding. And one of the challenges we have as anesthesiologists is determining how low of a platelet count is too low for an epidural. As a society and as a profession, we have set that level of about 70,000 as the rock bottom level when everything else is perfect. But 100,000 is when people start to get nervous. And so between 70,000 and 100,000 is no man's land, I call it, or no woman's land, or no person's land, where you're going to get a lot of disagreements on anesthesiologists and anesthetists as to whether it's safe to put an epidural in or not. And then that will lead to some frustration, particularly among the obstetricians, the OB nurses, in some cases the doulas, because they'll have a patient, they'll have an anesthesiologist who'll put in at 75,000, but another person won't. And so that's where the kind of the art of medicine comes into. But our goal in providing labor epidural analgesia is to do it in a safe way where the benefits far outweigh the risks.
I think it's helpful to for folks to understand like what their it's hard to sometimes gauge what the individual risk is, right, for that individual person, but it's very helpful to know that for most folks who get an epidural, the risks are very minimal. I have supported families through, you know, that spinal headache and migraines that are really, really debilitating after birth, and having support people in your space to kind of support you through that and getting you back to the hospital for the blood patch. But it is very rare. It's a very rare complication. So that's helpful for, I think, a lot of people to know that even though we're talking about these complications, and it's very important for you to know that these complications are a risk, even the risk of, you know, elevated risk of cesarean after having an epidural for multiple reasons, from blood pressure to, you know, anytime you introduce an intervention, you're kind of increasing your risk of other interventions that are needed. But there shouldn't be too much fear kind of going into this, as long as you're, you know, eyes wide open, and the anesthesiologist that you're working with is going to do kind of a one-on-one look at your chart and make sure that you're a good candidate. So if folks are interested in looking into another alternative to epidural, maybe there's a fear of needles, so they're looking into another pain medication option to get rest or what have you kind of throughout their birth process. Are there any other significant risks that are significant or insignificant to the general population that you hear about a lot, or that you think folks should know about, you know, for example, like fentanyl or morphine for labor?
You know, the risks of fentanyl or opioids are that you time it so that the baby gets it and the baby's born quicker than you anticipate. And if you're in a hospital, even a lower resource hospital is able to deal with that kind of neonatal depression. If you're at a higher level of care, then they're absolutely capable of dealing with a neonate with respiratory depression. And so opioids, we really worry about the neonate for that. Now, for nitrous oxide, very controversial on the long-term effects of nitrous oxide. And so actually I moderated a pro-con debate 6 years ago at our national meeting, and we had two experts take the pro and the con side, and we just don't have that great of evidence to say one way or the other, are there long-term effects from nitrous oxide. So nitrous oxide messes with an enzyme called methionine synthetase that's involved in vitamin B12 metabolism, which is involved with DNA metabolism. And so theoretically, it's possible there could be some long-term effects, but we don't have any great longitudinal data that suggests it's either safe or unsafe. And then for hospitals have to worry about the occupational hazards, because if operating rooms are very well ventilated and they're very more controlled, they'll do samples of the air, because the OSHA says you have to have a certain parts per million of nitrous oxide, otherwise you're endangering the workers there. And so some hospitals have shied away from providing nitrous oxide because they don't want to go through the administrative and the legal liability of having to test and be accountable for high levels of nitrous oxide for their employees. Say you have a person who's pregnant, like a labor and delivery nurse who's pregnant, and she's caring for women who are getting nitrous oxide, and then she has a miscarriage. You know, was it due to the nitrous oxide? Probably not, but you don't know for certain. And so I think some of the hospitals just want to avoid that situation altogether. But I think the pain management choice is a very personal one, and there's no right or wrong answers. And it would be very uncommon and rare for you to encounter an anesthesia personnel, being an anesthesiologist or a nurse anesthetist, who's really trying to push you to have an epidural and will shame you if you don't have one. That's not really the goal of what we're here for. We're here to support your choices. And there's going to be some women who want an epidural. There's going to be some women who don't. Some birthing persons who want epidural. Some birthing persons who don't want an epidural, and that's all fine. We are here to support you and your decisions.
I love that. So we've all heard the story, I think, of a mom who did want an epidural, and the birthing person comes in and says they want it, but then they're already, fully dilated and effaced upon arrival. Are there any other instances like that? And I guess we could lean into that a little bit as well about times when parents should aware of where they wouldn't be able to receive that epidural or another pain medication based on I know we've talked about, the opioids, for timing around, not affecting the neonate as much as possible. But are there any other instances? And I guess what is the reasoning? I think it's helpful for folks to know about why they wouldn't be able to get an epidural at a certain time.
Yeah, so that's a great question. So obviously, like we talked about before, safety first. We don't want to do anything that's unsafe for you. And so if you are at a point in your labor where the baby is just about to crown, that's probably not the best time to have you holding still while we're putting a needle in your back. And so the good news about that scenario is that it's if you're that far along and it's moving that quickly, you're probably going to have a baby pretty soon after that. And whatever pain you have is going to be very, very brief. And then if you need some kind of repair afterwards, the obstetricians are usually pretty good about numbing you up. Like they can do a pudendal block even after delivery if they need to do a complex repair. And so there are lots of different reasons why people can't get epidurals that are unique to them. And so we call them maternal comorbidities. And so, like I said, if you have a problem with bleeding, if you've had spine surgery in the past, and there's a bunch of hardware where we would put our epidural needle, we usually don't like to do that because one, it introduces the risks of infection. We don't want to infect that hardware because that would be a devastating complication to have to remove all that hardware. And then the other thing is that the epidural relies on normal anatomy because we're putting this catheter in this space and we're injecting medicine through it, and we're relying on normal anatomy to distribute that medicine throughout the epidural space. And if you have previous spinal surgery, sometimes you can get scarring, or we call adhesions, that make it difficult to give you good pain control. Now, there have been some studies that have demonstrated these patients can get good pain relief, and I will put epidurals in patients who've had previous back surgery, but I tell people up front that they have a higher risk of it not working compared to the patient who hasn't had back surgery. And so when we talk about informed consent of the risks, and so it's very difficult to get a true informed consent from someone who's under the duress of pain from contractions. If you come in and you're contracting every 3 minutes, it's some of the worst pain in your life, you're going to let me do whatever you think I can do to relieve some of that pain. And so sometimes we don't always have the best circumstances to explain the risks and benefits. I think the best way is to educate yourself beforehand, like in sessions like this. You can really think about what kind of pain management options you would like, what kind of risks you're willing to take. And that way, when you arrive either in labor or if you're going to have an induction, you are better equipped to make those decisions on that day.
Yeah, I love that. And kind of leaning into that informed consent, I think is a great segue that from the perspective of an anesthesiologist, how can a pregnant parent advocate well for themselves at their birth, both with their anesthesiologist and other support folks in the medical community who are supporting them in that space?
So I've seen a lot of patients come in with birth plans, and I think that a birth plan is a good idea. And I think that there's two sides to a birth plan. I think that a birth plan is really good because it articulates what you desire, you know, what you want from your birth. Now, ideally, you would go over this birth plan with an obstetrician or a midwife or a doula beforehand, and kind of have some shared decision making and draft this document together. Because some of the things that you may think you want, or things that you want, may not be realistic. Like, for instance, I would never tell someone who I'm about to put an epidural in that they're not going to experience any discomfort. I can't take away every single unpleasant sensation with labor. It's just unrealistic. And so I think that if you really sit back and think about what you want during your birth experience, you write those things down, and you meet with the people who are going to help you through your birth, whether it's a home birth or a hospital birth or birthing center birth. I think that you're going to get a realistic sense of what's possible, what you can expect. And I think that overall, you probably have a better experience than someone who just shows up cold without having done that homework beforehand.
Yeah, definitely. I think one last question that I would love
Of
to add
course.
in here is, if we're thinking about, you know, an epidural and someone's saying like, I think I want this. You just mentioned just a bit ago that, you know, when you get an epidural, it doesn't take away every sensation or feeling. What is normal in an epidural that's working ideally, and what are people going to feel versus like, what is it going to mask?
So with an epidural, we're trying to create what I call a magic trick, where we take away the painful sensation of the contractions and of the baby coming down through the birth canal. But we leave enough sensation so that you can perceive the contractions and that you can engage in pushing the baby. And so a so-called perfect epidural would be the pain is mostly gone, but you can feel the contraction coming on, and you have enough motor function left that you can actively engage in trying to push that baby out. Now, there are some circumstances where the obstetricians want to do something called a passive second stage, or laboring down. And that's basically where we numb you up and the baby just kind of drops down through the birth canal through no active effort on your own. And in some instances where some patients, the physicians don't want them to push. So you got something going on in your brain, or say you got like something wrong with your heart, and they don't want you to do the so-called Valsalva of pushing. Sometimes the plan will be for us to give you such a good epidural that we allow the baby to passively come down the birth canal, and then the obstetricians deliver it by a forceps. And so it's a unique circumstance. It's something that would absolutely be discussed beforehand. No one's going to surprise you with that kind of plan. But that's an example of how we, as anesthesiologists and anesthetists, work in concert with the obstetricians and the midwives to try to make the best outcomes possible. So to summarize your question, what we really want to do is we want to take away pain, retain the motor function, retain the ability to feel the contractions.
Yeah, that's really helpful. I think regarding laboring down, just a kind of a little note since we're on that topic, it's really helpful to kind of understand what those terms mean when you're preparing your birth plan, about like the station that the baby's at. And a lot of the things with laboring down, you know, if you don't have a heart condition or something that's wanting them to keep you, where they're wanting to keep you from bearing down and putting any strain, is it can shorten your pushing time that's needed, even with an epidural, if your baby is, +1 or +2 station instead of like the baby being really high. So that's something that you can definitely find more information about, and I think is really helpful for folks to examine when they're looking at, creating their birth plan. So Dr. Hofkamp, do you have any final encouragement or recommendations or advice for parents when they're creating their birth plan to make sure that they're comfortable and have a positive birth experience?
I think that I would just try to go through what you value as a person and what you want the birth experience to be. And I think that there's no right or wrong answers. An observation that I'll share is that I think that doing a non-medicated birth is entirely possible. I also think it requires a lot of what I call attentional capacity. And so, like, if you're doing it unmedicated, every single contraction, like, you really have to put your mind into dealing with that contraction. It takes a lot of mental and emotional energy. And that's where the doulas come in, to hold your hand, or a supportive partner. And this is just my observation, I have seen people become very fatigued. It's like running a marathon, and it takes a lot of energy to get yourself through those contractions unmedicated. And for some women, some birthing persons, that's a very important part of their birth experience. And it's important to them to do it that way without medication. And we support that. There are other women who say, you know what, this is not what I want my birth to be. And I have encountered women who have attempted to do it unmedicated. Then we'll go in when they're 5 or 6 centimeters and they're kind of pooping out, and we'll put the epidural in, we'll give them some good pain relief, and then that'll allow them to take a nap because they don't have to deal with really focusing through every contraction. And then they'll save their energy for the last part of the labor, when now they gotta like wake up and really push that baby out and give it their all. And that's just one observation I've had. I don't place any value judgments on any of these decisions. I think that it's highly personalized. There's no right or wrong way to do this.
Amazing. That's very helpful. I think that, yeah, like regardless of what your birth preferences are, having a plan and making a discussion, listening to educational pieces like this so that you understand the pros and cons while you're in not in your labor mind, is a very, very smart idea, and can really make a huge impact on the positivity of your birth experience and how happy you are on the other side of it, and how supported you feel through the whole process. So I am opening up for Q&A. So if there's any questions you have, feel free shortly to come off mute or drop them in the chat. I already have one, but before we get to that, I would love to have you share where folks can connect with you online, and we'll go from there.
Probably the best way to connect with me is in my Twitter account, at Hofkamp Michael. My DMs are always open. And so you can just drop me a DM, or even post something and say, hey, what do you think about this? And, if you wanted to open up to a larger discussion, I'd be happy to do that.
Wonderful. Thank you so much. Perfect. So someone asked, your thoughts on laughing gas and Pitocin at 38 weeks. I'm assuming they're asking about an elective induction, and the timing of an elective induction.
So the obstetricians, as I understand it, the most recent ACOG guidelines are that elective inductions can be done at 39 weeks. And then if it's before 39 weeks, it needs to be a medical indication. And so there was a study that was done recently that didn't show actually showed better outcomes at 39 weeks induction compared to trying to go into spontaneous labor. And so I think that your obstetric plan is outside the scope of my practice, to give really good advice. But my understanding is that, there's risks and benefits to getting induced versus waiting. I can tell you that for the birth of our second child, my wife was incredibly stubborn about being induced and was induced at 41 weeks and 5 days. It was at the point where, because her obstetrician was very good, she was supporting her decision to wait to go in spontaneous labor. But once it got to 41 and 5, the obstetrician said, all right, enough's enough. We have to get this baby out. And so I think there's risks and benefits to inductions. My observation and my practice is that a lot of people do inductions based on convenience because they want to have the baby on a certain day. Sometimes it's for the convenience of the obstetricians, depending on the practice model. There are some practice models where the obstetricians will cover the labor and delivery unit 1 day a week, and that's their day to deliver babies. And if you want to be delivered by your obstetrician in a practice model like that, you need to have your induction on that day. And so, every situation is unique. I've known physicians who've done home births. And so there's different levels of risks with each birth plan that you take. And I think that the birthing person has the ultimate agency to make those decisions for themselves.
Definitely. Yeah, I think is the study that you're referencing the ARRIVE study?
I would have to look it up. I'm sorry.
Okay.
It's
Yeah,
like 39 weeks, it's 39 weeks with induction versus waiting, for spontaneous labor.
I think if anyone's looking for that, I think you could probably find that study as well as any others kind of around that conversation on like when to induce. I know that a lot of data shows that there's distinct risks to going beyond 42 weeks of pregnancy. So I think there's definitely a window, and there's, kind of based on early dating ultrasounds and all of those things, like babies grow at different gestations and things like that. But then there's a distinct cutoff where the risks outweigh the benefits for an elective induction versus waiting for spontaneous labor. And I think that depending on your provider and what your personal risks are for your healthcare and your health history, I think that's a great conversation to have with your provider. And also, like, how favorable is your body to an induction at that moment as well, because that can determine basically how well your body takes the induction and what your risk is for having a cesarean. And those are all like really good questions, like as you get closer to kind of like ask your provider, like, is my cervix already showing signs of effacement and dilation? And then have that conversation then around, what would an induction look like? Would it be better to, a lot of times they start, if your body's already showing some favorability towards an induction, starting with a Foley bulb or Cervidil or something like that, rather than jumping right into Pitocin, because folks who have Pitocin inductions do tend to choose epidural more so than folks who go into spontaneous labor, who are more dedicated towards like, hey, I want an unmedicated birth. And that's just because Pitocin doesn't really come with those lovely endorphins that natural oxytocin comes with. So it can make contractions feel a little more intense for a lot of people. So the troopers are the moms who have an elective induction and do that unmedicated. That's a real trooper. Another question for you. Elizabeth asked, if someone wanted to do an unmedicated birth, but then the contractions got to be too painful, what is the latest that they could wait before they're changed their mind on getting an epidural?
That's a great question. I would think that typically about 8 to 9 centimeters dilation, that's when we really start to think about whether or not the benefits outweigh the risks. That being said, you could theoretically do it at 10 centimeters dilated, and different anesthesiologists and anesthetists have different preferences in how to position the patient. I prefer to have the patient sitting up. There are some people who prefer them laying down on their side. I'm able to do it laying down on the side, and it's not my preference. I think it's technically easier to do it sitting up, but I think that if you're really close to having a baby, it would be safer to be laying on your side. And I think it all boils down to the comfort level and the experience of the person who's doing the procedure. There will be some people who will really be aggressive and they'll do it, almost to the point where the baby's crowning. And there'll be some people who say, "Oh, you're 8 centimeters. Sorry, I don't do it 8 centimeters." So I would say that that you really, if you want an epidural, you're dealing with real units with real human resources problems. And so on a labor and delivery unit, they try to provide enough coverage to do C-sections and labor epidurals. And sometimes you get so many cesarean deliveries back to back to back that the anesthesiologist or anesthetist just simply can't go and do the epidural because of emergencies or other issues. And so that usually doesn't happen. But my recommendation is that it's kind of like if you're on the highway and you kind of have to go to the bathroom and you see a nice gas station or a truck stop, you probably want to stop there because you don't know when the next truck stop's going to be. So
yeah, definitely. I've seen a lot of like 30-minute delays before an anesthesiologist can get into a room, sometimes an hour and a half, kind of depending on the cesarean. So if you're thinking that's something you want, you can definitely ask your L&D nurse what the options and what the timing would look like and kind of when their recommendation would be. A lot of times too, when it comes to epidurals, just really kind of thinking through the length of your labor too, because a lot of times sometimes there's long periods of prodromal labor, which is early labor where there's not a lot of changes in the cervix and it's just very exhausting because you don't really get a lot of sleep. And so sometimes making that decision kind of based on if your labor is, 12 hours versus 72 hours and what that looks like. And, if you're induced or dealing with prodromal labor, that can change your birth plan. And I think that's where having a little bit of flexibility in your birth plan can be really helpful when you're talking to your providers and other folks. And if you're interested in learning more about making a birth plan, I will make a quick plug. The inside of the Better Birth community, which I can send the link out, we have a really great resource, a short course. It's about an hour of content on how to create a birth plan and how to determine what's the right kind of path for you to take based on what your preferences are. So that's a great resource, and I'm happy I can pop that in the email that we send out to everyone with the replay link for this chat today. So does anyone else have any other questions? If not, we'll just wrap up the chat for today, but thank you so much for joining us for this chat. I think this is really helpful and gives just a full scope on the options that are available to you in the anesthesiology space as you go into your birth. Good luck. Very exciting. If you need any resources, we're here for you. Definitely reach out to our team at Anja if you need anything. Reach out to Dr. Hofkamp on Twitter at Hofkamp Michael if you need any resources there or want to ask him a question as well. So
thank you very much, Amelia, for having me. This is a pleasure.
Yeah, wonderful. Thank you so much. All right. Have a great afternoon, y'all.